Thank you again. My name's Daniel Blaney Cohen. I'm an attorney at the American Medical Association in Chicago. And I'm going to introduce our speakers. And I want to try to ground the discussion and we have. And if you see me tap the phone over here, it's it might be my kids asking for something, but it's more likely I want to keep on time. So that's the reason I'm doing that. But one of the things I talk a lot around, I travel a fair amount, like Rob and Tracy, and try to ground the discussion a little bit. And every part of the country is different, right? That's one of the many Captain Obvious kinds of things that I'll say today. But one of the things that I think is notable, at least from the start here, the concept of service, I think is something that I think everybody's going to hear about today and is really important. We're going to talk about service in national ways, but try to bring it down to a local perspective and try to provide some best practices that hopefully that people can take away. The faith. Faith is a critical part of many people's journey, not to be discounted, but to be held up by everybody. And faith, whatever the faith is, even faith in your community. Faith in whoever is providing treatment, faith in your family, faith in a higher calling, essential. Hold on to that faith, and I think in gratitude. From the AMA's perspective, gratitude is not necessarily a healthcare policy, right? And we're going to be talking about policy and how to implement policy and how to ground that into actual practice. And we're going to talk about those kinds of policy things. And one of the things that I was reminded of when we were talking about preparing for this today is I want to start with my personal gratitude to Gordon. And many people know Gordon here. He's a scion of Maine. And I first met Gordon and Andy McLean, who's here probably close to 25 years ago. And I think grounding policy in implementation and practice is certainly what we try to do. We don't want to be at the 25,000 foot level of policy. I work on a daily basis trying to get laws passed in states. But we don't want laws to be paper tigers. It doesn't help anybody to get a law passed and nothing happens as a result of it. It has to improve the lives of individuals. And I think that's where we want to try to ground this. And the second area I want to try to ground the discussion today, and hopefully you'll see this, and this is what guides my work and guides the work of the AMA, are two metrics. There's lots of data, right? Maine has one of the best data hubs really in the country, but I think it boils down to two metrics in terms of what we're talking about in terms of policy and whether we're going to support or oppose a policy. And the first one is, does it help save lives? Does it stop people from dying? Just brass tacks kinds of things. Does it reduce harm, stop people from dying? If it doesn't stop people from dying, I think we have to ask, well, why are we supporting that policy? And the second one, does it improve outcomes? Does it actually help people? So these are not, I'll introduce our speakers in a second, but Tracy is an epidemiologist, nationally recognized epidemiologist, and my science colleagues at the AMA, they're like, Daniel, those aren't real metrics. And I'm like, well, they kind of are real metrics. Like I'm a lawyer, so like I tend to think of things a little bit more simply than my scientific colleagues. But I think about today as we talk about everything. Does what we're doing reduce harm? If it doesn't, then let's think about that. And does it help? And those don't have to be mutually exclusive, right? They can do the same thing at the same time. So that's sort of where we want to ground those policies. And the other, keep in mind today, we're not going to be able to talk about everything. Absolutely not talk about everything. So if we don't get to something, it's not because we don't love it. It's not because we don't work on it. It's just we're gonna finish at about like 11:20 here. We want to hear the governor, and your governor is one of the nation's leaders in terms of helping ensure that the policies are such that can be implemented to help individuals on the ground. And we don't say that about every governor in every state. We don't say that about all of the work that's being done in every state. The 1,000 Lives campaign is a campaign that we would like to see implemented in every state. And that takes the medical community, it takes the entire executive branch, it takes many other branches of government, the Attorney General and others, to try to make that happen. So that's where policy comes to ground. So I want to introduce our two speakers, and I'll introduce Elizabeth, who's going to be on the screen. She's hopefully the only one who doesn't laugh at the jokes that I may or may not tell. Rob Morrison, he's the executive director of the National Association of State. I'm going to get this wrong because the old title, but NAZADAD, and Rob will tell you what the new, I heard it for the first time yesterday, but NAZADAD. And basically, Rob is this national, and I've known Rob for probably close to 15 years now when we were starting to work on this. He's going to provide some important perspective on this epidemic. But Rob works with the people who are doing the work in the state, who do the work with the people on the ground. So when it comes to understanding where the best practices are in the state, there is no one better in this country to provide those best practices from across the country. And all of those state grants, all those block grants that states receive, Rob is one of the most tenacious fighters in Washington, D.C. to protect those funds coming in so you can do the work that you're doing on the ground. And it's been an absolute privilege and I have immense faith in Rob's continued work and gratitude for the work he does. Dr. Tracy Green, she is, she's a researcher, a professor, an epidemiologist, and I've had the privilege of knowing Tracy, I think, for at least more than a decade. So like a true researcher, the evidence guides her. But I think as we go through today, she's also one of the most compassionate people that I've worked with, in this field. And again, lawyer compassion, right? That's those work together really well. And one of the things that Tracy has done through her research and her work has provided the AMA, at least, with guideposts and clear direction on where, for example, harm reduction policies need to be. And I think as we start out, and Rob's going to talk about this, where we were 10, 15 years ago, and Tracy's going to help us talk about where we still need to go, grounding it on the front. So I am grateful for our speakers, and please join me in introducing them. So to begin, we're going to hear from Dr. Elizabeth Salisbury Afshar, who in the best of everything, she's a practicing physician. And so, and our speakers have to scoot away. But I wanted them to be in front so you could see them. And Elizabeth is going to talk about, Dr. Salisbury Afshar is going to talk about why treatment alone is not sufficient to end this epidemic.
Hi, thanks so much for having me. My name is Elizabeth Salisbury Afshar, and I just want to start by apologizing that I can't be there in person. I had the flight, got there early, did all the things, and the airline universe just did not work in my favor yesterday. Daniel asked me to talk about why I feel treatment alone won't be sufficient to end harms from the current overdose epidemic. And I just want to start by saying, I'm an addiction medicine physician, so I wholeheartedly support addiction treatment and continued focus on the expansion of patient-centered, trauma-informed, culturally responsive addiction care. I know that treatment works, and I probably, like many of you, know countless individuals for whom substance use disorder treatment, medication treatments have supported people to recover. But the reality is, and I know this is no surprise to anyone here, treatment alone won't be enough, right? And we really have to continue to work to expand the conversation beyond treatment to really take a hard look at some of the social and structural factors that both contribute to the development of addiction and contribute to the sort of challenges that make it so hard for people to recover when they are struggling with some of those negative outcomes associated with substance use. I actually had a whole list of talking points from this sort of socioecological lens, and but the reality is I participated in an echo yesterday, and one of the cases that someone brought to discuss has really just stayed with me, and I'm instead going to use that as a case example. So at a high level, The case was that there was this case was brought by a clinician, and she was working with a female patient who, like so many of our patients, had a long history of childhood trauma, intimate partner violence, had experienced homelessness, had a past felony, was currently on parole, and actually had been engaging and doing quite well in treatment for her opioid use disorder and alcohol use disorder. Was on buprenorphine, was doing really well, was stable, and had a slip up and experienced an overdose. Now, this patient and clinician lived in a state where they don't have a good Samaritan law that protects people who are on parole. So because she had an overdose while on parole, she was going to go back to jail. So her offense was that she experienced an overdose. Now, the woman knew she was going to go back to jail, and also knew that the jail in her community wasn't going to offer medication, wasn't going to allow her to continue buprenorphine, right? So she self-tapered. She went to someone's home and self-tapered because she wanted to be able to withdraw in the comforts of someone's home where she could take other medicines and get some care from people who cared about her, and then presented to the jail. When she was released, she had a return to use and died. And the clinician brought the case and asked us what we thought she could have done to change the outcome, right? Because they had this close relationship with the patient. They had been offering all kinds of evidence-based therapies, trauma therapies, medication treatments, and still had this really, really awful outcome. The reason this has stayed with me is because, to me, when I look at this, we just see system failure after system failure after system failure, right? So no one should be incarcerated for experiencing an overdose. It's a medical event. They should have access to medical care, not a legal response. So that was the first, actually the first policy failings and structural failings were probably, her childhood experiences and the many traumas she had up to that point, as well as lack of affordable housing and housing opportunities. Those are really the first policy failures in my mind, right? That sort of set up the circumstances that make people so vulnerable to developing addiction in the first place. The next is that we now have a system where someone overdoses, our response is to put them back in jail. Jail is not treatment. Jail is not therapeutic. Jail is traumatizing. So now this woman knows she's going to go back to a jail where evidence-based treatments will not be offered, which, by the way, is a violation of the Americans with Disabilities Act. But many of us, myself included, continue to live in states where that happens on a regular basis. So she takes matters into her own hands. She tapers herself off the buprenorphine at home, goes to jail, and when she's released, then has returned to use and dies. So we see this terrible outcome and all of these possible places along the way that the systems could have been improved. Again, I just want to relate that the clinical treatment team was doing everything they could. They tried to outreach. They were trying to get in touch with family. They were really worried about her. But as long as we continue to live and work in a system where the primary response at a societal level is a legal response that increases trauma, and particularly in environments where we are not offering evidence-based care in these carceral settings, we are continuing to do harm. And so, my takeaway from that case is you as a clinician, you did everything you could with your clinician hat on. But until we start to push and advocate, and I do think we all have an important role to play in advocacy, until we continue to push things forward, continue to acknowledge the role of trauma, the role of homelessness, the role of educational opportunities, the role of living wage jobs, right? Like the role of all these structural factors, and very importantly, the ongoing harms that some of our drug policy continue to create. Until we address those things, I really think we're just going to keep nibbling around the edges. We maybe can see a plateau, maybe even some reductions in death. But until we truly start to address these broader social and structural issues, and I didn't even mention racism, I have to mention racism as an important component. We know it's a stressor that many people experience on a daily basis. And we know that racism plays out every day in the legal system. So until we can truly start to figure out ways to address some of these broader structural issues until we can start to really say we're going to take the evidence and we're going to put it into policy, and we're going to create systems and structures that support people to truly get better. I think we're going to continue to struggle and continue to see overdoses at rates that are absolutely unacceptable.
Okay, that's Elizabeth. So thank you, Dr. Afshar. Want to go and bring your chairs back. So as Tracy and Rob are setting the chairs back up, I want to build on this systemic issue. And remember, we're not going to eat the entire elephant today, but figure out where can you take a bite. Leave here thinking about, all right, I'm going to chew on that. That's what I'm going to be chewing on today. We're not going to be able to get at everything, and they're going to dish it up for you. So Tracy, let's build on the systemic and policy challenges, both, successes, and certainly there are areas where there are failures. Should I close this?
No, but I got it now.
All right. With respect to harm reduction, and sort of an open floor for you. We've talked about a lot of issues today. Whether harm reduction means lots of different areas. So go ahead and pick one, and tell us about those challenges, both from the policy side and the implementation side.
Yeah. So okay, great, works. Hello, everybody. Well, I think I wanted to pick up a little bit on something that Elizabeth's. The patient case that was presented, and kind of missed so many missed opportunities to intervene, but especially, the social determinants of health are huge, and we can spend our lifetime, and our society needs to absolutely shift on all of the factors that she brought forth. And this is actually one of the key motivating factors in the meantime to reduce the risk and reduce harms that the systems and these social determinants of health are introducing at every step of the way. So, for that patient, perhaps had she had naloxone at release, perhaps had she had access to MOUD, such as the Sublocade program that is here in Maine, had she returned to a community where she knew what the drug supply was like, the toxic, unregulated drug supply that surrounds us, had there been a safer supply, either in circulation because policymakers and law enforcement had worked to make that be, or because she knew what she was seeing and going to be returning to, or along the way, harm reduction had been integrated into every possible aspect of of the touch points where she was crossing paths, all societal aspects. These are all strategies that we have to kind of still work towards, because we don't have treatment access for all, because we don't have erosion of racism, and because we don't have systems and structures that can support humanely and with respect and with the dignity that is deserved people who are using drugs. So in this opportunity, I think I was at the harm reduction and recovery meeting that Director Delvin Rittman had spoken of in Colorado, and just listened to two communities really trying to find their way in how can we actually work together, or can we work together? Are we the same? Are we different? How are we really going to be able to move forward in an uncertain political and social structural future? And I think one woman really spoke to the importance of harm reduction, not as being integrated, not as this backup plan. She said, harm reduction doesn't need to be baked into the cake. We are the cake. I think that really spoke to me on so many levels of really centering the principles, the components, the vision of harm reduction that brought me to this 33 years ago as this high school student, and continues to this age. I will not state, you can do the math. I've been doing this a long time. But as a researcher kind of contributing, laying the ground for harm reduction, that to be not just the backup plan, but the plan. And so in doing this, kind of giving clues, I think as Daniel had alluded to policymakers and states, as well as to other allies, medical professionals, nurses, pharmacists, and along the way, many others in the community who can pick harm reduction up and see themselves and see the fundamental aspects of what is being asked to be recognized, give space, give voice. And so a lot of the research that I and others in the harm reduction community who are researchers really tried to do is to lay that out. We did this we did it pretty well in a couple places. I'm really proud of how naloxone is now on the shelf of every pharmacy. It's pretty awesome. I'm pretty excited that Remedy Alliance exists because of exemptions that FDA has put forward. This all did not happen through just research alone, but it certainly helped to answer questions, many of them, like, can people who use drugs identify overdoses when they're happening and when to administer naloxone? Can people safely administer naloxone? And can they be trained, people who use drugs, can they be trained to carry naloxone? Can we, if we increase naloxone to a certain level, very high in the community, do we see mortality reductions? Can naloxone that's given to people who use drugs be done so and be accessed in multiple places? Does increasing naloxone in the community increase risk and risk-taking and drug use? Can naloxone be provided in multiple places, the emergency department, the prison, the hospital, vending machines, the Veterans Administration, housing environments, and be misused? Do we see high-dose naloxone having a better and helpful effect? All of these are questions that we have been able to answer. I personally have answered many of these questions in papers, but they only go so far without the voice of the community and other allies who can pick up this research, lift it up, but also, incredibly importantly, lift up the voices of people who are surviving because of naloxone. And I can imagine there are a lot of them in this room and a lot of them at this meeting. And so centering the people who use drugs in the work that we do and in the policies that we put forward is really the only way we've, I think, gotten to where we have been. I'm a small pitch for research. This isn't to say that you shouldn't keep doing it, because every legislation that goes forward has citations, and all of them need to be strong, and they need to be absolutely crystal clear. The good thing is, it actually seems to work. So it's not like we're making data up. It's not fake. It's actually distinctly real that this medication does one thing extremely well, consistently, whoever's hands it's in, but especially in the hands of people who use drugs, can it do even greater benefit. So we can get to things like saturation and think about policies to think about how much naloxone needs to be there through science, and it's never absolutely perfect, but it gets you far enough to know that what we're doing is insufficient because harm reduction isn't yet the cake. It isn't recognized as the cake. So as the plan, we have a lot more to do, but it is, I think, a policy success to say that we have naloxone in this country in many different forms, in many different places, but we have a lot more to go to do.
So implementation. Let's talk implementation. We're on a wonderful campus here. I'm hopeful that some of the other buildings have naloxone rescue stations in public places. I don't know if they do. Maine law allows that. Has it been implemented here? Many communities have schools. How many people are in a school district where naloxone is available from the school nurse, or students are allowed to carry it? All right, there are probably some others who isn't sure if your school has it. It's a great thing to take back. Talk to your administrator. Maine law allows it. Do we carry it? And Tracy, let's go a little bit into, you mentioned drug checking. So drug checking and safe supply. I don't know that we're ever going to get to a place in this country where there is pharmaceutical grade illicit substances that can be dispensed from pharmacies. That seems like a pretty far bridge. However, talk a little bit about the technologies and what can be done on the ground to help people who use drugs identify what's in their supply.
Well, I would beg to differ. We do actually have pharmaceutical-grade medications and fentanyl already administered, actually under supervised conditions in our hospitals everywhere already. So we do actually already have many of these consumption spaces. We just don't recognize them as such in the same sentence. But in terms of drug checking, and I think this is a really emerging and promising area where we continue to see, again, a whole laundry list of research really contributing to, in this country, how it might be extremely effective for fentanyl detection, so that we can see what is circulating in the drug supply, but what else beyond fentanyl, because there are certainly many things that contribute to people's health and risk. Phenacetin, for instance, these are simple additives that we see as cuts. Levamisole and other contaminants that xylazine more recently, I think thinking of these things as perhaps they're not an opioid or a stimulant, but they are something that may affect treatment success, treatment delivery, and that healthcare providers should have the access to this information. But sure enough, the people consuming absolutely need to be the first and foremost communicated, or the one communicated to, of what's in their drugs. And in doing so, we have an opportunity to understand and look at trends and better align our responses so that we can shift to and respond appropriately. As a researcher, that was critical when we started to see that fentanyl was starting to take hold in New England areas, and thought that, looked around to see, well, how would you ever know? Why do we have to wait for someone to be hurt and harmed in the hospital setting or to die before we knew that fentanyl was contributing to their death? And to dispel that, we started to look to, well, who knows about what's in the drug supply? The police typically know where it's in the drug supply, so do the medical examiners, but the tools that are used in that environment are lab-based. There are field-based, and a whole panoply of field-based detection tools that law enforcement have had for a long time that have not been in the hands of people who could actually use them. So liberating, if you will, democratizing, removing and increasing transparency in both what we can use and who has access to them pretty much fits the bill for naloxone too, right? It only can be prescribed or only be used by someone who's a medical professional, can only be administered by an EMS professional. That is pretty much BS, and it has been, as we've seen now, after not just many studies, but after, as you saw, again, thousands and thousands of administrations and lives saved year to year. Fentanyl test strips are a good example, and the more comprehensive tools that we have in community drug checking, like at Project Dharma, is emerging in Maine, which is really exciting. And pretty much every state in our Region 1 now has access to at least fentanyl test strips and hopefully comprehensive drugs checking services. In this way, people can literally have access in real time is the vision. It's our, if you will, the constellation of harm reduction we're looking for, not just that North Star. But in there is the opportunity for people to know that what is contained in their drugs, and that is the full collection, so they may adjust who they use, where they use, the information and who they share that with, and to stay safe. And in that way, we have a chance for anyone in the community to come around this particular, we all want to know what's in the substances we take, how much caffeine is in the coffee that you're using, how much alcohol is in the beer versus the vodka versus the latest thing that is on the shelf at your liquor store. We have an opportunity in a regulated environment to understand what's inside of the substances that we're putting in our body. People who use drugs, the people who care for them, the people in the community have every right to know what is also in the drug supplies that are circulating. This should be both a no-brainer for anyone who is working on this topic. Otherwise, we are moving forward in a policy black box without any information. And destined to have the patient that Elizabeth spoke of to be ill-prepared for the substances that they may or may not be returning to use.
Thank you. Rob, I want you to follow up on that with so much of what has happened in terms of naloxone saturation. Commissioner Delphine-Rittman mentioned 10 million doses of naloxone distributed through SOR and TOR grants. If it wasn't for naloxone, I shudder to think of what this country's death toll would be like. Thank God we don't have to think about even more tragedies. But Rob, take us through sort of a two-part question. One, give us a little perspective on how far we've come. A little bit of the Wayback Machine. But then, also take us forward. And, Commissioner Squirrel mentioned what, we agree is an unbelievably exciting pilot about Sublocade. And maybe talk through, a couple of other areas that may not be aware to everyone in Maine, but then how, through your agency directors, that pilot can be based on and expanded upon in other states.
So thanks for having me. I represent the National Association of State Alcohol and Drug Agency Directors, and Daniel was talking about taking out the word abuse and putting in agency. Took us since 1971 to figure that out, so I'm glad we got there. I'm also humbled to be here because a lot of folks who served in those roles in state alcohol and drug agencies are here in this audience. So they're probably chuckling to say Morrison is giving a reflection of how long he's been in the field. when they taught me up. I first entered the work in 1994 for a United States senator, and then I went to this association in 98, came back in 2001. And I was pretty good at this, analyzing Section 501 of S765 and telling people we needed to add 2 words to it, and explaining the role of state alcohol and drug agencies. I got better at that. And then I got confident over a spell, talking about the issues, too confident because in my own family, someone needed help and I didn't know it. And they emailed me and said, I need help. And I said, I don't know what to do. I'm running around telling people how important I am and talking about alcohol and drug issues. And I don't know how to help my own family member. So folks in this room helped me get there. And she's in long-term recovery now because of it. And so for me, that journey then said, I got to get in the rooms. I got to go out and see programs. And I've spent the last 24 years doing that. And then this past Thanksgiving, I got a call checking in like we all do with relatives. What are you going to do? Where are you up to? And family in another state. And they said, I can't talk right now. I got to go. It's Richie. Hung up the phone. And another family passed away and died on the day before Thanksgiving, the very day we're supposed to all celebrate and spend time. So the juxtaposition of thinking I know and then being humbled and building back up, and even with all that work, watching someone die, it's humbling. I'm not as sour as Elizabeth is. I think we made a lot of progress. In 98, we'd go to the Hill. If we could get in the office, if we could get the meeting on alcohol and drug issues, they brought out 2 staffers, and they would joke. We had to bring the guns person and the drugs person. Guns and drugs, right? I'm looking at Penny Mills, who is executive director of ASAM. And just getting in the door was difficult. So fast forward to now, I think one challenge as we walked away, as we were educating the federal folks because of you, we got to a point where the deaths were just increasing, and I was introduced to folks like Daniel. And all we were doing was meetings and briefings and meetings and briefings and meetings and briefings and meetings and briefings. I said, when are we going to get to the money that's needed? And we got a $500 million investment. In our field, we didn't use letters to describe funding with a B. And now we're at $1.5 billion every year for a grant program outside of the $1.8 billion. And we represent the director of squirrels of every state. And the last thing, Daniel, you talked about naloxone, and Tracy's done so much work on this. We ourselves, as an association, didn't make a statement on naloxone until like 2009, 10, or something similar. Until a New England state director named Ms. Barbara Smoglio, many of you know her hub and spoke model, and that's another interesting thing to reflect on that now we think is standard that we didn't have. She says, if we couldn't be about saving lives, what are we about? Conversation was done, statement was drafted, and we worked with governors' offices on their anxiety, because there was anxiety. So I take us back there because it was people in recovery and people with experience who taught us up and made it real and turned this abstract stuff into real help. So those are some thoughts.
And one more point about naloxone, because like I said, we're not going to talk about everything, but we're spending a lot of time on naloxone because why? Because it saves lives. All it does is save lives. So we should talk a lot about it. In Chicago, I go into my local pharmacies. There are hundreds of local pharmacies all over the place, and one of the first things I do is I look for where the naloxone is. There's only one supermarket where it's not behind the cash register or behind the pharmacy counter, and so the pharmacist always appreciates that I take up his or her time with asking why, as the line behind me gets longer and longer and longer. I encourage everybody, take up your pharmacist's time and ask why. And hopefully that message gets back to the corporate parents. Because the AMA has written lots of letters, we've had lots of talks, but if it's not on the shelf, is it doing anybody any good? And I would say no. So all of those corporate partners need to do a much better job. It's a little homework assignment. Let's stick on doing a better job. And in particular, doing a better job about thinking about things that make us a little uncomfortable. And overdose prevention centers make some people a little uncomfortable. And we get that. But let's have that discussion. Tracy, tell us a little bit more about your work and observations about overdose prevention centers. And we're going to start going a little bit rapid fire because we want to leave a little bit of time to questions before we have to leave to go to hear Governor Mills.
Yeah, so overdose prevention centers, or OPCs, are the term I'll use because they're known by many other names, especially across the pond in Europe, where they have been in existence for multiple decades. Actually, kind of like drug checking and a little bit like naloxone, these are ideas that aren't new, but that actually have very much a place in our current drug crisis, but they aren't necessarily well known in the U.S. And so part of what we have to do, I think, as we elevate the conversation and think about them in our cities and our states, and consider them as possible symbols, really, of the highest level of tolerance of harm reduction and the principles of safety and watchfulness, and recognizing also that an overdose that is unwitnessed is very likely to turn fatal. So the opportunity to improve witnessing and the opportunity to improve touch points through another possible prospect where coming into this space is one where someone is known to be using drugs is an opportunity to also talk with them and support them in what they may need and provide them supplies and resources. It's very different than a touch point in a hospital setting or a touch point in a prison or a touch point in a pharmacy. So that aside, this is an opportunity for really to raise a level of understanding of what an OPC is. And I'd encourage you, there's a ton of literature this high of papers working to help us understand that they save lives with respect to mortality or overdose mortality in particular around the geography in which they take place. They are not a solution at a writ large state level unless you have many of them. They will only be responsive if they can be localized and be part of what a community has decided is part of the collection of things, the continuum, that constellation of harm reduction and other services to support people. And in doing this, we see that arrests do not increase, that 311 calls do not increase. We see that the community is not impacted in negative ways, and instead it becomes part of the fabric of responsiveness. And this is data that we see from Vancouver and in our continent. We see in Vancouver, as well as more recently in New York City from several of the sites that have opened there. Now, they did so not in particular in these locations. In Canada, I actually had a hand in that. I was on the Health Canada committee. I did my master's degree at McGill. My master's thesis was on willingness to use supervised injection facilities in Montreal amongst 250 people who use drugs in that community. I had the pleasure of hearing from and talking with 250 people who were injecting primarily cocaine, but also what was thought to be heroin at that time in that community, and learn from them what they were, why would they go, was this concept important to them. And along that way had, being strangely an American who was invited to the Health Canada table, a level of interest and tolerance. It was great. But to sit with many people from across that great country and really bat around this idea, should we not, for 3 days in multiple languages of Canada, to discuss this. And in a really committed policy debate, they voted to recommend a pilot. That pilot became Vancouver's first supervised injection facility in North America. The data that came from that and the basically the equivalent of Supreme Court laws that were required to move and sustain the existence and now expand to over 40 sites across Canada, stand as examples, and I encourage you to take a look at and visit those in Quebec. I just saw them, the same ones that I was asking about. Would you be willing to go? What would they look like? How would you like them to be? They actually exist, and I walked through them last month. It's pretty awesome. I actually went because they were doing drug checking, and I wanted to see how that worked and how that integrated into their care services, that constellation of harm reduction services that are provided in a local level. But here we have an opportunity in America, from Rhode Island, where I work at Brown and Rhode Island Hospital. We have passed legislation that was signed by the governor. It was passed through the legislators. And we were able to, in the middle of COVID, get overdose prevention sites passed. It went through a fully vetted regulatory system process of conversations and community gatherings, feedback. Those regulations, you can find them on the website. There was an RFA process. It's a totally legit healthcare community, fully regulated by the state of Rhode Island. It will open hopefully in the next couple months. We'll be happy to provide drug checking services until they're up and running and can do it themselves and have all the tools that they need. But in the meantime, what we're talking about is an environment that integrates health, treatment, harm reduction in a very actively centralized way, with the doors always open, and in a way that really allows us as a country, I think, to learn how this could be done in this way. I encourage you to take a look at some of the communications we've been having with our community policymakers. We did a simulation, a literal installation. We actually did that at American Public Health Association too. It was our largest conference. We had 10,000 plus members, and we simulated an overdose prevention center to see what that was like. For our policymakers, though, we did this during COVID and opened one up in Providence just before the law passed. And it was actually really interesting. The vast majority of people who went through to visit were the treatment providers, people who were very skeptical and wanted to understand what this is. But our policymakers came through too. And I think it had a part in really visualizing this thing that isn't like a wild card. It's actually very much looks like many of our other low barrier, high touch point locations that we want to offer in any community. So take a look at some of the resources on opcinfo.org. This is a public facing website that allows for information about OPCs. And our COBRA on opioids and overdose at Rhode Island Hospital, an NIH-funded center, along with Brown, developed this. There's a visit you can do virtually on what an OPC looks like. But in terms of thinking about this, these incredibly important touch points and inviting policymakers and others who may be curious about what this is into this literature and in this space is part of the most important kind of ground level things I think we could do as we consider these ideas.
So think about, just to be clear, the AMA strongly supports these pilots. And Rob, I want to give you the last question, then we do want to take a couple minutes for questions. So Rob, the last comment, talk to everybody a little bit more about, as Maine and other states consider the sustainability of pilot projects and the sustainability of grants, as Maine considers, how are we going to use our state opioid litigation settlement funds? Is a one-year pilot sufficient to truly make a difference, Rob?
Nope. But we also know you start there, and then collectively, if you could go to your state legislature and Congress to ask for 3 to 5 year grants and explain why. A lot of folks assume now that we have the Affordable Care Act and we have Medicaid expansion that you all have everything you need and that you don't need any more money or support. That's the frame of reference we have on Capitol Hill still, believe it or not. And we need your help as folks who do the work to explain the type of things that are under reimbursed or they're not reimbursed at all, or what's missing in your world for salaries, training, support, all the stuff that you know you need more for. We need education to explain that. And part of that too is sustainable grants that last more than 1 year. The CCBHC model also embeds a more predictable and sustainable approach to financing where Medicaid's involved. And so moving towards financing models that are predictable. So the job's hard enough. And then you got to fight for the privilege of keep doing it. So that your voice is everything. And you don't have to be an expert in paragraph 2 of S756.
Sorry, Rob. Dr. Salisbury Afshar would have talked about a walk-in clinic that she's established in Wisconsin. It's on a 2-year grant. It took a long time to just hire the staff when the grant was started. So already the clock starts ticking. I think we have time for one question, maybe 2 questions, and then we'll be around if anybody has a question. Yes, sir.
The question I have, I want to be very careful because I know a large part of this conversation is surrounding naloxone, but I'd like to talk about the research coming back from some of the overdose production sites in which we're finding that the addition of the availability of oxygen plays in overdose prevention and also lessening of traumatic brain injury due to, suffocation, and why aren't we having those conversations and getting something like as simple as oxygen readily available in overdose situations?
Yeah, that's thank you for the question. And I think this is part of a larger conversation about response to overdoses in the age of fentanyl, in the age of xylazine, in the age of many of the opportunities to respond with oxygen can be like an overdose prevention center where you have medical support you have pulse oximeters and you have additional medical supports. But oxygen in particular and the trainings that people are doing in overdose prevention response, if they don't include rescue breathing as a central component, that is one of the most important things to revisit and perhaps lift up and to make sure that people who are connected to community programs and getting connected to community naloxone have oxygen supportive airways and rescue breathing as one of the 3 things that they take out of that day. Good SAMWA, the rescue breathing, and then how do you administer the naloxone. Those are critical, and the OPCs actually do have beautiful data showing, and this is, the Europeans do not actually administer naloxone at all, if ever, but oxygen supports are absolutely something that I think we'll start to see more of, and watch the research because it will be part of this, and it complicates the response in the environment for sure, but it is absolutely critical that we talk about it. So, yeah.
I want to thank everybody for your time and attention, and please join me in thanking our speakers.